Good morning, everyone. Welcome. Thank you for showing special interest in this special interest group meeting on alcohol-associated liver disease, and ACLF. I welcome you all on behalf of the INASL organizing committee for the first session of the day. We'll be starting off with 2 abstract presentations, followed by Meet the Experts panel discussion. I invite the chairperson for the abstract presentation, our very own Professor Sivaram Prasad Singh, sir. Sir, please raise the stage with your presence. So please raise the stage with your presence. The first abstract will be presented by Dr. Patal Giri. And sir, the session is yours.
Yes, sir. Good morning, sir. Thanks.
Yeah, please start your presentation.
Good morning, everyone. I am Dr. Patal Giri, Junior Resident, Internal Medicine at PGIMR Chandigarh. I'll be presenting my work entitled Impact of Outpatient Intensive Nutritional Therapy on Survival and Frailty in Patient with Acute and Chronic Renal Failure. As we already know, ACLF patients are at higher risk of malnutrition due to insufficient nutritional intake, and that results in frailty and sarcopenia. And ACLF patients with frailty have more complicated disease course requiring frequent hospitalization, and hence that result in poorer outcomes. Many studies have shown that lower BMI in ACLF patient is associated with higher morbidity and mortality rate. So despite enormous literature demonstrating negative implications or poor prognosis of frailty in this patient, data on frailty is still sparse. So we carried out a study hypothesizing that improvement in nutritional status by outpatient intensive nutritional therapy can have beneficial impact on survival and frailty in patient with ACLF. Our aim was to determine the impact of 3-month dietitian-supported outpatient intensive nutrition therapy on survival and frailty in ACLF patient. So it was a single-centered randomized control trial where we recruited ACLF frail patient, adult ACLF frail patient, and some of our exclusion criteria were the patient having high disease severity score like MELD more than 30 and ARC more than 10, the patients having active malignancy or having ongoing infection, and those who were too sick to perform physical performance test. And ACLF patient, those were recruited as per the APASL criteria. Frailty assessment was done by liver frailty index criteria using Frail calculator, and this is the one. And here we asked the patient to perform hand grip strength, and then second holding 3 position balance exercise, and the third one was time to do 5 chair stand. And using and considering the gender of the patient, we calculated the liver frailty index, and the people having liver frailty index more than 4.5 were considered frail. So after recruiting the patient, their demographic and lab investigation and baseline anthropometric measurements were noted. Nutritional assessment was done by our FSGA criteria using 3 tools, that is BMI, MAMC, and dietary intake. So patients were allocated into a study arm. The first arm, that is OINT group, includes monitored high calorie, high protein, and salt restricted diet along with a standard medical therapy, as well as the other group, that is control arm. SMT group include standard medical care for the ACLF patient and regular nutritional recommendation. And as per the INASL guidelines, our target calorie was 35 to 40 kilocalorie per kg per day, as well as total target protein intake was 1.4 to 1.7 gram per kg per day with salt restriction of up to 2 gram of sodium per day. Patients were followed weekly for first month and then monthly for another 2 months for dietary monitoring. This is the overall chart we used for prescribing the diet for the patient. That includes 3 major meals, including 5 snacks. 4 snacks were given during the daytime, including 1 late evening snacks to avoid the duration of the fasting in such patient. Treatment compliance and adequate nutritional intake monitoring was done by 24-hour recall method, as well as the patient were asked to maintain the food diary. This is the food diary chart that was sent us by the patient. Nutritional assessment was done by using DietCal software, and this is the software where we feed the data, and it gives us the total calorie that the patient has taken throughout the day. Now coming to the result, this is our consult where we screened a total of 120 patients during the duration of 1.5 years in our OPD. 50 patients not meeting the inclusion criteria due to the various reasons were excluded, and we enrolled total of 70 patients that were randomized 1:1 by computer generated number into group A, that is YNT group, and group B, SMT group, and were followed up for a total period of 3 months, where we see the impact of our therapy on survival, change in frailty, change in prognostic scores, and complications requiring hospitalization. These were the patient characteristics at the baseline, and here we can see they were age and sex matched, and we totally enrolled 70 alcoholic male ACLF patients during our study. So coming to our primary objectives, which was to see the survival at 3 months, survival was much higher in our YNT group as compared to the intervention group, and we also carried out a regression analysis to look for the independent predictor of survival at 3 months, where intervention, that is the patient who receives the target-oriented diet, has much more survival as compared to the SMT group. Our next secondary objective was see improvement in frailty, and here also we can see that there was a change in frailty over a period of 3 months, but the delta change was significantly higher in YNT group as compared to the SMT group. And then we also carried out a regression analysis for looking independent predictor for liver frailty index, and here also enrollment in the intervention arm was the independent predictor for change in frailty along with a baseline ARC score. Our next objective was to look for improvement in disease severity, and also here we can see that there was improvement in the disease severity score more in the intervention arm as compared to the SMT group. Anthropometric measures BMI change was more in YNT group as compared to the SMT group. At the baseline, as per RFHGA criteria, 50% were 50 and 45% were in moderate malnutrition, severe malnutrition group. But after our intervention, none of the patients remain severe malnourished. So here we can see the compliance of the patient after repeated counseling, where their target calorie intake and the protein intake was gradually increasing. Also, we look for the complications in both the group. So the frequency of complications were lesser in YNT group as compared to the SMT group. So we concluded outpatient intensive nutrition therapy significantly improved the survival of ACLF patient. There was a significant improvement in liver disease severity score and reduced number of complications. And our finding also support the intervention for standard medical treatment in ACLF patient. Strength of our study was, it was very approachable and practicable interventional study. Diet plans were curated according to the regional and cultural eating habits. Careful and regular follow-up was done by the study dietitian for treatment compliance, and regular counseling of the patient was given regarding the importance of restoring nutritional reserves. The limitation is it was a single center study with modest sample size, so further validation is required. We have excluded the EASL ACLF patient as they were very sick, that is male more than 30, and this could have potentially affected the result. It was a short-term follow-up study, so long-term of nutritional therapy and outcome and frailty could not be assessed. And change in SMI was not evaluated as 3 months is too small to document change in the muscle mass. Thank you.
Thank you, Dr. Giri. Now the presentation is subject is open for discussion. Dr. Jalan. Yeah.
Dr. Patal, good study. Wanted to ask how many of the patients actually completed the In the intervention arm, you gave them an exhaustive diet list. How many could actually take that? How many actually couldn't complete the set amount of calories and protein? And did you overcome that by giving any supplements to them?
Sir, almost all the patients in the YNT group, because of our repeated follow-up, either by phone call or regular meeting with liver dietitian, so most of the patients, except three patients, they followed our target diet that we were supposed to give them. Even during some time, due to the complications, even during the hospitalization, we make sure that they took the recommended diet as per our protocols. Sir.
Well, thank you. This is really exciting, and I think that, with achieving such amazing results with nutritional intervention, and nutritional intervention studies are so difficult to do, so many congratulations.
Thanks,
My question is really about the mortality in the control arm. So you have a risk of death at 3 months of 45%
Sir.
in that in your control population, which is really much higher than what you would expected with the patient population that you have included. So the question really is as to how is your control arm being managed? 45% readmission rates with a risk of death of 45% is enormous. So can you tell me a little bit more about what you're doing with the control group in your over the 3-month follow-up?
Sir, considering the fact that 3-month mortality is very higher in ACLF patient, and to begin with, we begin with the control arm, giving them the same diet chart that were given to the intervention arm, but the follow-up was done in the control arm in the OPD basis, and they were not like in regular contact with one-to-one with a liver dietitian. They were followed as per our OPD basis. That is generally done with all the patients, but for the intervention arm, they were regularly in contact with a liver dietitian, sir. So that could have affected our results, sir.
Can I ask a follow-up question? So you see, what we know is that frequency of intervention, interaction with a patient who is being followed up in the clinic makes a difference, because every time they show up, if they have a problem, you intervene. So patient and your dietitian, was any doctor involved in that follow-up over the 3-month time frame in the treatment arm, where you are continuously attending to complications that may be arising, preempting? So the question is, can you distinguish between nutritional intervention and human intervention with respect to the patients in the treated group? That makes sense.
So the treated group were regularly in contact with me as well as my consultants, sir. So all their were small queries or everything were being answered. If that could not be solved by us, they were brought in contact with the liver dietitian, be it any time, sir. So this is how we went through our study, sir.
Thank you.
Thank you, sir.
Thank you, Dr. Giri.
Thanks.
Thank you for a good presentation. Next, we have a presentation on unique lipid signature in ACLF patients. And for this, I invite Dr. Rohini Saha to make the presentation. Rohini, please.
Innate with ready to adapt. Neutrophils, one of the most abundant innate immune cells in our body, have been
Please go to the mic.
have been long known to be a homogeneous population of cells with limited functions. But over the past few decades, neutrophils have been hailed to be one of the most versatile cell types, which can adapt to their microenvironment and also respond to immune metabolic signals, which is very interesting. So hello, I am Rohini Saha from AIIMS New Delhi, and today I'm going to talk about how lipid mediators modulate neutrophil function and associate with 28-day mortality in a background of an inflammatory disease called ACLF. ACLF, as we know, is driven by systemic inflammation. The tissue damage-derived DAMPs and the PAMs from the leaky gut often contribute in this inflammatory condition. Now, we know from the hallmarks of ACLF that there is involvement of innate immunity, and there is an elevation of NLR, or neutrophil to lymphocyte ratio, which is again associated with mortality. But we often find a neutrophil dysfunction in ACLF. There is reduced phagocytosis and ROS generation, but the molecular targets of this dysfunction is yet unknown. Now, due to the excessive hepatic damage, we can also hypothesize that there will be release of lipid mediators in the system because liver is the hub of all metabolism. It causes fatty acid synthesis, lipoprotein packaging, and various lipid metabolism process. But the involvement of lipid alteration in ACLF is not very clearly known. So this brings me to the aim of my poster, which was to identify circulating lipid species in ACLF patient and investigate their immunomodulatory role, and these were my objectives. So first, to identify molecular targets from a transcriptomics experiment where we took circulating neutrophils from ACLF and validate the findings, to identify lipid mediators which are involved in 28-day mortality, and further to investigate the immunomodulatory role of these ACLF-derived lipids on healthy neutrophils. Now, these were my methods. First was to do a blood PMN transcriptomics using microarray in ACLF patients, and CLD healthy were taken as controls. Then we did a plasma lipidomics experiment. So lipidomics, just like genomics and transcriptomics, we look at the entire global lipid species in the system. And here we took ACLF survivors and non-survivors, and as well as healthy controls. And finally, we developed a cell-based assay to understand whether these lipids have any immunomodulatory role. So our microarray or the transcriptomics data revealed that there were hundreds of genes which were altered in ACLF. As you can see from the heat map, as compared to ACLF versus CLD and ACLF versus healthy, the log-fold change of the gene expression was tremendous. And as we did a pathways analysis of this gene set, we found an upregulation of a neutrophil pathway known as neutrophil degranulation. And some of the candidate genes which were involved were CD177, a GPI-linked glycoprotein present on the surface of neutrophils, and cytotoxic enzymes such as ELANE and MPO. If we just look at the granule formation inside neutrophils, so degranulation is a very natural process for neutrophil, but excessive degranulation might lead to cytotoxicity, which is also evident, cytotoxicity and tissue damage in ACLF. Now, when we validated our study using the CD177 as our target, and then we looked at the CD177 positive neutrophil subsets in ACLF and compared with CLD and healthy, we observed by flow cytometry that almost 90% of neutrophils in ACLF are CD177 positive. So we have a neutrophil expansion, and majority of them are already CD177, so are already poised for a pathogenic neutrophil subset. Now again, when we looked at CD177 gene expression in survivor, non-survivor, we found that non-survivor are the ones which harbor such a high CD177 positive neutrophil subsets. So we conclude from here that CD177 is definitely overexpressed in ACLF, and there is some connection of this particular gene or protein with 28-day mortality. Next, what we did was we did a lipidomics experiment, and we identified that across ACLF 28-day survivor versus non-survivor, there is an upregulation of a lot of phospholipids. So if you look at this volcano plot, the red ones are the upregulated lipids and the blue ones are the downregulated. So in the upregulated, there's a signature, unique signature of phospholipids such as phosphatidyl-inositol, phosphatidylcholine, serine, ethanolamine, and so on. And now when we looked into the literature, phospholipids are involved in neutrophil phenotypic processes, one of them being neutrophil degranulation. So if we imagine a neutrophil with a phospholipid bilayer, for the degranulation to happen, there is restructuring of the phospholipid. The granules go and bind and fuse onto the phospholipid, and there is release of the granule. So upregulation of phospholipid, and particularly phosphatidyl-inositol, in non-survivor cohort can link it back to the degranulation process, and hence an increased mortality. So to understand and validate this finding, we developed a cell-based assay where we took healthy blood cells. Now healthy, as we remember, have downregulated CD177 protein as well as gene expression. We added the lipid extract from the non-survivor. Now it was to see whether they can regulate this CD177 gene expression if they are modulated by lipids at all. So for this, we incubated them for 24 hours and then did a qPCR gene experiment, expression analysis, and we found almost 15-fold upregulation in neutrophils which were treated with ACLF-derived lipids. Now, so we can hypothesize safely here that ACLF-derived lipids do induce CD177 gene expression, and we could mimic the neutrophil phenotype in a healthy control which already had a downregulated expression of these two. So we can conclude from here that yes, there is neutrophil dysfunction in ACLF. We have identified some of the signature molecular targets. Now the CD177, one of the GPI-linked cell surface marker, is upregulated, and there is also phospholipid upregulation. And if we try to link both of them, yes, the neutrophils are immunomodulated by lipids, and there is a 15-fold upregulation of the CD177 in healthy. So immune dysfunction in ACLF can be now addressed by understanding the lipid mediators and their role in modulating neutrophil phenotype. I would like to thank my guide and my team members and also my collaborators. Thank you.
Thank you, Rohini, for this wonderful paper.
Thank you, sir.
And the paper is now open for discussion.
Well, many congratulations. This is really exciting.
Thank you, sir.
I have two related questions. Okay, so when you have a lipid extract, do you also have liposaccharide in that mix?
So we do have a control, a positive control, where we use lipids and LPS and a lipid and an LPS separately. So this experiment which I showed was only using ACLF lipids, no LPS here.
But I suspect that you would believe that in a ACLF circulation,
Yes, sir.
as you know, we know and we published before, there's very high concentration of LPS
Yes, sir.
circulating LPS. So how do you know whether this effect of cross-incubation of ACLF plasma with neutrophils is not due to circulating lipopolysaccharide?
Okay, so we have done an experiment where we have used purified LPS as a positive control, but we do not find this kind of an upregulation of this particular gene. So maybe there's LPS plus the added, lipid mediators in ACLF, which is contributing to this.
Can I make one suggestion?
Sure, sir.
So what you might want to do is to deplete
Okay.
the plasma that you're incubating with of LPS
Okay.
using some sort of a column or removing it in some
Right.
other way
Right.
to see as to whether you see the same thing in isolated cells.
Right.
It is just to close that loop
Okay.
such that you are taking away the component part of, the second part is also damps, as you know, that they can drive similar changes that you have, and a lot of them have lipid mediators associated with it. So it may be worthwhile thinking about how you can deplete those in order to see whether it is pure phospholipids or something else.
Okay. Thank you for the
Thank you.
suggestion, sir. Thank you.
If there are no further questions, thank you.
Thank you, sir.
Please take your seat. That was a very nice paper. Congratulations. And with this, we move on to the next part.
What a stimulating discussion this morning. Now I can see a small galaxy of luminaries in front of me in the audience. This is for the Meet the Experts panelist discussion session for the morning. It will be moderated by none other than Dr. Orko De. I'll just invite the honorable experts on the stage. Our very own SP Singh sir is there, and Dr. Rajiv Jalan sir and Punita Tandon ma'am have come all the way to join us. Please, ma'am, sir, grace the stage with your presence. I now invite the panelists for the day, Dr. Thareja sir, Dr. Nitin Jagtap sir, Dr. Mithun Sharma sir, Dr. Girish Pati sir, Dr. Sandeep Satsangi sir, I'll hand over the mic to Dr. Orko De sir. Have a seat, sir.
Okay, half of the panelists. इधर आ जाओ सर. Okay, good morning, everybody. So the session was supposed to be moderated by Dr. Nipun, so I'm just filling in for him because he's not here. So we have this patient, Mr. R. He's a 32 years male from Sangrur, Punjab, and he presented with yellowish discoloration of his eyes for 30 days, along with abdominal distension for the last 20 days, and cough with shortness of breath for 2 days. The jaundice was progressive without any prodrome and non-cholestatic, and the abdominal distension was not associated with any orthopnea, PND, or pedal edema, and there were no altered mental status of bleed or reduced urine output. This was his first presentation. There was no similar episodes in the past, no comorbidities, and he has been abusing alcohol for the last 15 years with a daily intake of around 100 to 120 grams per day, and the last alcohol intake being 30 days back. So for these complaints, he had been admitted outside where he was evaluated and found to have cirrhosis, and then he was referred to our institute because of new onset respiratory involvement with cough and shortness of breath. So on examination, he had tachycardia, tachypnea, his blood pressures were normal. He required oxygen with an FiO2 of 40% to maintain his saturation. He was icteric and had pedal edema. On systemic examination, the abdomen was distended with full flanks, and free fluid was present per abdomen. And on auscultation of the chest, we could hear crepitations in the right upper and lower quadrants of the chest. The other systems were within normal limits. So these were his lab parameters. He had anemia. There was leukocytosis with a TLC of 27,700. Thrombocytopenia was present. His INR was 2.25. Bilirubin was 19 with a direct component of 15. AST, ALT were 109 and 24, and alphos was 153. So these were the imagings. Chest X-ray showed bilateral pleural effusion and infiltrates, which were corroborated on the CT findings. His ascitic fluid workup revealed a low protein high sag ascites with no SBP, and the pleural fluid was also a high spag low protein pleural fluid with a normal ADA, and no evidence of and a normal ADA. So the ultrasound was suggestive of a cirrhotic liver with ascites and other features of portal hypertension, including dilated portal vein and splenomegaly. The upper GI endoscopy showed low-grade esophageal varices. Urine examination was normal. The urine and blood cultures were sterile, but the sputum revealed septate hyphae. Procalcitonin was 0.9. Beta DG was 138, and galactomannan index was 1.1. These were his scores. His ARC score was 10. The CTP score was 13. MEL sodium was 32, Cliff C ACLF 48, and an MDF of 102. So the first question to the House about the diagnosis: do you think the patient has ACLF? So how many of you think that the patient has ACLF? So I think everybody should agree that the patient has ACLF. So Sandeep sir, by what definitions do you think he would fit into ACLF?
So I think
his BMI is 22. It's
So I
not
think-
mentioned, sir. I know that there are many discrepancies.
So I think this is classically by a PASL definition, wherein first you have jaundice, within 30 days you have ascites. The Billy is more than 5, INR is more than 2.5, so I would call it as a PASL related.
And does he fit into canonic also?
So he has definitely liver failure, so his INR is more than 2.5 as well, so yes.
Yes. And so the only thing he's not fitting into would be a NACL criteria. So you agree with that? Okay, so he fits into both the PASL and canonic, but not NACL, because the NACL would require, 2 organ failures, which would be either the patient is in HE3 or 4, or he's intubated for, he's on ventilatory support, or he has got shock or requirement of renal replacement therapy. And the acute component here appears to be a severe alcoholic hepatitis, with the sepsis having complicated the course of the alcoholic hepatitis. Do you think that this patient has sepsis? He's infected. Does he have sepsis? Again, with a show of hands. And if you think that he has sepsis, what infection is it likely to be? Fungal infection. So again, I don't think so we need to discuss this, because obviously he's got septate hyphae on his sputum. The beta-D-glucan and the galactomannan are elevated. We know that the cirrhotics are at a very high risk for developing infections. And on the basis of the beta-D-glucan and galactomannan, it's likely that he has got Aspergillus species. So I think all the panelists would agree with that.
Can I ask a question here?
Yes.
So here, what you have sort of suggested is that this is an alcoholic hepatitis driving the syndrome. And what you have is evidence of fungal infection in his chest. So what came first?
Sir, I feel that this alcoholic hepatitis here came first because he had the jaundice and ascites ongoing for 1 month, and he's been symptomatic for this chest infection for just the last 3-4 days. So I think it's complicated by an infection. So the infection is a complication rather than the precipitating event in this case. That's my opinion.
Because he's been abstinent for a month.
Yes.
So is that, so you need the presence of ongoing alcohol abuse for the definition of alcoholic hepatitis. So he's not drinking when he comes into the hospital.
Yeah, not when he's coming to the hospital, but at the time of the onset of jaundice. He's just stopped it when he has developed the jaundice. He's been having jaundice for the last 1 month. So he's stopped the alcohol use when he felt that he is developing jaundice and ascites.
So what you're saying is he was decompensated for a month, and now 2 days is
Yes,
free of
now he's
respiratory-
basically come with this respiratory
Respiratory infection is 2
complaint.
days.
Yes,
All right.
yes, yes.
So the question is, what is the precipitating event for his ACLF here? Is it his previous alcoholic hepatitis or alcohol-induced liver injury, or is it the acute infection that has led to him being hospitalized? I think this is a critical distinction, because in my book, he will be classified as somebody who may have had alcoholic hepatitis, but he has a dual precipitant, which is what PREDICT would suggest. So if you look at, and his prognosis, therefore, is going to be extremely different to that of a pure alcoholic hepatitis or pure infection, because what he's now got is 2 illnesses which is driving his story. So background story may well be alcoholic cirrhosis with possible alcoholic hepatitis. We just do not know, because he's drinking till a month ago, he's not felt so well, which is fine, but his hospitalization is related to this chest infection.
Agreed.
And so therefore, what I would put to the panel really is as to whether he can be diagnosed as ACLF using a parcel.
So the question was, when was he diagnosed as ACLF? Was he diagnosed after he was admitted to the tertiary center, or was he diagnosed at the time he was already referred to you? So that will be the differentiating point.
So I think the patient can be diagnosed only when he comes to the physician, but the patient has the syndrome or the disease irrespective of whether he comes to the
He's
physician.
referred from somewhere, so
he's been having the jaundice and the ascites fitting into the parcel even before he came to us. So we know that there are so many scores for the assessment of prognosis in liver disease. So Dr. Mithun, if you could take it up, which scores we should be using in patients of ACLF?
So at our center, because we are following the parcel definition, so we use the ART score, and since there's a component of alcoholic hepatitis, or whatever we call it, alcoholic cirrhosis with superimposed hepatitis, we would combine it with definitely the MEL and a very high DF of above 100. If there was no infection in this case, it rules out the use of agents like steroids and all. But at our center, the most common score that we use is the ARC score. Can combine it with the MEL score, and DF of obviously has been done already.
And what about the CLIF-C scores?
CLIF SOFA is used because it's the ICU has it in the protocol, the CLIF SOFA. But when it start prognosticating the patient in ACLF, we use more on the ARC and the organ failures in these patients. CLIF SOFA has obviously been done for all the patients with ACLF.
No, the point I'm trying to raise is that he fits into the definition of by both the parcel
By both.
and canonic. So
Both.
which do you think would be better in this kind of a scenario, the ARC score or the CLIF-C ACLF score?
Because the infection has already set in, the CLIF SOFA would probably give us some more additional information than the pure ARC score. That's
Right.
my
And your opinion on the role of dynamic scoring, and when should reassessments be performed for this dynamic scoring?
So dynamic scoring, so it's basically being done actually on a day-to-day basis, but in the presence of infections, a score here at the time of around, say we do it at 48 hours is what we take a time slot where we decide whether there is a response or there is no response. But I don't know whether dynamic score adds anything to the outcome unless and until the patient shows improvement in terms of the infection part. But the prognostication part starts early on the first day itself when the scoring has been done. And if you have to move these patients for transplants or anything, we don't have time to wait for another 5-6 days to tell them that we need it. The others can comment on that.
So before I take Madam and Sir's opinion, just to the House, so how many of you think that in these kind of scenarios, the CLIF-C ACLF score fits best? How many of you first and foremost think that the MELD score or the MDF scores are best applicable in this scenario? So none of you. And how many think that CLIF-C ACLF, I just saw 2 or 3 hands, and how many of you think the ARC score is the best to be fitting in this scenario? So before again I take the opinion of Dr. Jalan and Madam, so this was a little study that was done on the ARC consortium, and they evaluated all these different scores at 0, 4, 7 days, and what they found that the day 7 ARC scores had the highest C index, and importantly the day 7 scores, outperformed the day 0 and the day 4 scores, which shows the dynamic scoring. But to my mind, the interpretation should be that it doesn't really, whichever score we are using, if on the dynamic scale it is worsening, the patient is worsening. If on the dynamic scoring, the patient is improving, he is improving. So, ma'am, can we just have your opinion on that?
Yeah, no, I would agree. Let's just be practical. It's dynamic scoring over time, and if they're worsening, I would say I don't have a lot of experience with using this ARC, but certainly we would use the CLIF score.
Sir, any comments?
So look, for me, the problem is when you are super selecting the patients right at the outset with exclusion of a large majority based upon history does not really make sense. So we don't use ARC at all. We don't use a Basel criteria. We believe that organ failure is the key in driving end organ outcomes. Here what you have is a precipitant which is alcoholic liver disease with superimposed fungal infection, and the prognosis of this patient is going to be determined on between day 3 and 5 as to what happens to him. So fundamentally it is semantics, in terms of whether you use ARC, whether you use CLIF, whether you use INASL, and I think we have to think logically in terms of what are we doing with our patients. You're excluding patients with decompensated disease. You're excluding patients with infection. And then you're including patients in the diagnosis of the disease condition using infection and using a scoring system which is targeted at a pure liver insult. Here you don't have a pure liver insult. So fundamentally, what you have to consider is only using a scoring system which has been developed for that purpose. We've heard MDF. You have no diagnosis of alcoholic hepatitis here. There is, I don't see what the evidence for alcoholic hepatitis is. You're using MELD. And again, MELD, as we heard yesterday, underestimates the risk of death in this population. ARC is based upon a Basel, which is extremely difficult to apply in this situation because of the superimposed infection. So the only scoring system that you're left with is CLIF. And so, and that is what we will use in this situation, and you'll use it dynamically on a daily basis to define as to what will happen to them within the next 28 days. Sorry.
Can I just ask one question here? So do you think the liver is the driver, or it's the extrahepatic involvement or the organ failures which are important? Because is there a difference in mortality if the bilirubin is somewhere around 5, 6 versus 30, 35? What do you think is the driver here? Is the liver or something else?
Fundamentally, we believe that there is a hierarchy of organs. Okay, so liver, so here what you have is and we believe that the only hierarchical organ determining outcome is the lungs. The rest of the organs we think behave pretty much similarly. So single organ failure with liver, kidneys, circulation, the risk of death is the same, which you might have seen with canonic. The risk of death is a little bit lower with brain, 12%, and the risk of death with respiration is a little bit higher as a single organ failure at about 12%.
Kidneys.
So fundamentally, the range is between 11 and 21%, depending upon individual organ failures in a patient population such as this. And this was shown nearly 10 years ago by Richard in his paper.
I think all would agree that in clinical practice, if the bilirubin is coming down very quickly and it's not that high, the improvement in organ failures is very quick, even if it is, involvement of lungs or other organs. That's what the clinical experience is, our experience, what we see.
But again, you have, if you've got an accumulating kidneys, respiration, respiratory failure, bilirubin may be getting better, but the mortality is determined by accumulation of other organ failures. So again, as I said, that it'll be very rare for you to see an improvement of your liver function if there is superimposed infection or something else driving other organ failures. So it doesn't happen in isolation.
Okay, so the question to the House again is, assuming that he has got alcoholic hepatitis precipitated ACLF, would you be using steroids in this patient? Again, by a show of hands, please. So I think none of you would be wanting to use steroids because obviously he's got infection, he's got a fungal infection. Now, say we have treated the infection, say that he is a non-septic patient, then assuming that this is alcohol-related ACLF, AACLF, would you be using steroids in this patient? Again, by a show of hands. No. The sepsis is treated now. Assume that the sepsis is treated, he is infection-free. So in severe alcoholic hepatitis alone, not amounting to ACLF, we know that we are using steroids. But in severe alcoholic hepatitis with ACLF, would you be using steroids? Show of hands from the House. That's what, so he's not just a severe alcoholic hepatitis that is now presenting like ACLF. So nobody is in favor of steroids among the panelists, sir?
So the obvious answer to your first question is no with the fungal sepsis.
Yeah.
When it comes to the second question, yes, steroids in a second situation of alcoholic hepatitis with the ACLF without ACLF is more efficacious than when the setting of ACLF is already set in.
Right. So yeah, so we have this data from the STOPA group where they retrospectively looked at it, how many were fitting into ACLF as far as the canonic, and what they found that if it's ACLF versus no ACLF, there is a significant difference in the attainment of the Lille response in patients who do not have ACLF as compared to those who have ACLF. And in fact, if you look at the ACLF 1 and 2, can I have a pointer? Okay. So if you also look at this part in ACLF 1 and ACLF 2 and 3 in these patients, whether you give prednisolone or no prednisolone, they did not really find any difference in the Lille response. So I know that in India, actually, we use steroids, particularly in our institutes, we don't use steroids almost at all. So what is your experience with steroids, particularly in the setting of...
So would you use steroids still forgetting the infection? With a DF of
now let us all forget the infection, because infection will become a contraindication.
Let us forget the infection. The DF is 100 plus. So we have Joan's paper which came last year, I think, that anything above 51 is where the steroids don't start working. And there are also papers now where people have combined plasma exchange, reduced artificially the numbers, and then started adding a low dose steroids. So I don't know, because even without infection, with such a high DF, I'd be very reluctant to use steroid.
So ma'am, like in your practice, what is the MDF cutoff till which you would be comfortable giving steroids to a patient of?
It should be more than 32. If MDF is more than 32.
We know above 32, but what is the above limit? Like for instance, the last ASLD guidelines would have said above 90, there's no need, but we have evidence after that about cutoffs of 51, 64, like that. So in your practice, Professor Tandon, till when are you comfortable with giving steroids?
So we are comfortable till 51 we are using. But your question, would you consider the plaques in this patient?
No, this is not. We haven't come to this, please.
Yeah, sorry.
Yeah,
I use MELD more than I use DF, to be honest. So I think, was pointed out, Juan Pablo's paper on MELD was quite helpful with that window of efficacy. So certainly not in the patients who are super sick at 51. And we do use steroids quite commonly, but in this case, I would actually be thinking about a biopsy. To be honest, if we actually want to prove depending if he's settled down, to actually prove that this is alcohol-associated hepatitis.
Agreed. So how many of you would be considering plasmapheresis in a scenario of alcoholic ACLF? Again, by a show of hands. So I can just see Dr. Sunil raising his hand because we do the same. And Dr. Mithun also. So Dr. Mithun, if you could just tell us a little bit about plasmapheresis and its role
we have
in
been, all the trials of plasma exchange in ACLF have excluded patients with alcohol. I raise my hands because we have an ongoing study of plasma exchange versus standard medical care in a cohort of patients of alcoholic hepatitis. So the question is, if the infection is there, I would still be skeptical till I control my infection before I put him to a plasma exchange. And I will only use it when, to be very honest, if it's an ACLF, I have something on the other side of the window, like it's a bridge therapy always. In ALF, it can be a curative treatment. In ACLF, it's a bridge therapy. So we need to discuss with the family. I know in the West, transplant would not be discussed in this patient because of the alcohol history. But India, when you have a sister or a wife who is willing to donate, so the family, that pressure also comes in a real life scenario if this patient doesn't improve. So I would prefer to give it a try in this cohort of patients with an explanation that this definitely is not a permanent solution, or it's just a bridge therapy.
Yes, I think so. The very important point there is that plasmapheresis is not a definitive management. It's just a bridging therapy. So you're just buying some time till you can do something. And you were also talking about the role of combining Plex with low-dose steroids.
Yes, so there's a study which has come, I think, with Plex and steroids showing a better benefit than in patients who are ineligible. We usually have not combined that together, but maybe somebody else could have experience on that.
So yeah, we don't have any experience, but I think the Vellore group, the CMC Vellore group, they have the study of, low volume Plex. Low volume Plex means removal of around half of the patient's plasma volume, and then they have combined it with 20 grams of prednisolone, so half the dose of steroids, and then they found quite a significant, remarkable improvement in survival. What about regenerative therapies in alcohol-related ACLF? You have these GCSF trials in severe alcoholic hepatitis. So how many of you in the house would be using GCSF in this kind of a scenario?
We used to, but our experience was very bad, so we discontinued for last 4 years.
So I would agree to what Dr. Kamal Chetri said. We could not replicate the PGI data of 72% survival versus, I think, 30% with GCSF. We tried, we could not replicate the results in real life clinical scenario.
Yeah. So I think the PGI data would now be that there is a very large study which was presented last year in the ASLD, and that's a negative trial with the use of GCSF plus NAC. What about modulation of the gut microbiota? Would you consider fecal microbiota transplant in a patient with alcohol hepatitis precipitate ACLF? So any experience with FMT? So would you be considering FMT?
I think it's very dangerous, outside of a controlled scenario. And if I may just comment on the previous question in relation to Plex plus steroids, you have to be very, very careful. Remember that the thing that complicates the outcome of a patient with ACLF, where you make them non-transplantable, is infection. And we have a fungal infection in the background in this particular patient. We know that plasma exchange is immunosuppressant. And to follow one immunosuppressive therapy followed by another in a patient with a background of fungal infection is extremely dangerous. So therefore, small studies based with very few data where you are concluding is severe type 1 errors are present in these studies. And please be very careful when you interpret the results of these small trials to guide your clinical practice. And that is my only suggestion to you. 25 patients, and the GCSF is the best example of this overhype from 2012, that is, which has led to many studies being done since, which come out negative. So overhyped with small type 1 error defining studies you have to be extremely careful of in terms of not over-interpreting as to what you might see.
So I think there are two very important messages from Professor Jalan for the House. Number one, we should be careful when interpreting the studies. They have to be interpreted carefully. And secondly, on a background of sepsis, plasmapheresis is not very, we have burnt our hands quite a few times attempting plasmapheresis in the presence of sepsis. So, and there is also an FDA safety alert with the risk of very serious adverse events due to transmission of enteropathogenic E. coli and sugar toxin related E. coli. So it essentially should only be used in kind of trial settings. And finally, coming to liver transplant. So how many in the house are considering early transplants in patients with severe alcoholic hepatitis? Right. So, sir, if you can just comment on which patients do you consider for early transplant?
Except for the fungal infection. Okay, one by one.
Yeah. Which patients do you consider for early transplant in your practice?
So, if you were to take that Cliff score in him, it was something like 64, whatever it was. So that's a decent cutoff to consider ACLF for transplantation. You got a good, except for his fungal infection, right now the window was very good to give him one thing. But when to avoid, in his case, the only contraindication is active fungal infection. How long to treat, I really don't know the correct answer, but what I would do is definitely make sure that he's free for 4 weeks before I would consider him for transplant.
For 4 weeks. Ma'am, do you want to comment on that? Which of the patients you are considering for an early transplant and when do you not transplant?
Yeah, so presuming this is alcohol-associated hepatitis.
Let's assume that.
We're making a lot of presumptions, but we do actually consider them now for transplantation under what we call an exceptional criteria, and I think that's become much more common in North America in general. So obviously they need to meet certain criteria about non-response to steroids and good social support, being sick enough to be done. But we are doing more patients with this diagnosis.
So in India, most of it would be LDLT, but at least in our center it is GDLT. So from that angle, just like to ask you, so it is only those patients who are presenting for the first time that you're taking up, or patients who are presenting for the second or third, or that is those who have recidivism in between, are they also considered or are they out of being considered?
Yeah, so our criteria recently changed locally, so it was any presentation with any alcohol related complication previously would be a contraindication. And now it's just been refined to be presentations related to alcohol-related liver disease that are previous presentations to that are contraindications. So if they're coming in with second episodes of alcohol-associated hepatitis, we don't consider them.
Right.
Can I make a comment here? So this is a very complex patient, and it goes back to the beginning, okay? So in the UK, we're not allowed to transplant alcoholic hepatitis. But we can transplant patients that are alcohol-related cirrhosis with something else, all right? So here, we come back to this whole point that Punita talked about earlier, that a biopsy is absolutely critical in terms of defining whether they're transplantable in the UK or not. So if he has got alcoholic cirrhosis with infection driving his story, where you'll get mainly cholestasis as opposed to alcoholic hepatitis type picture, I could push him through to being considered for a liver transplant. But if he had alcoholic hepatitis, which is driving his disease, then it's not semantics, it's real, because it's life and death for this chap. And so therefore, infection driving it will get a transplant. If it is alcoholic hepatitis driving the story, he will not get a transplant in the UK. So, you know, it is really, really important to think. In terms of your last question, I think the important thing is to think about what are you going to do after a transplant. So what drugs do you have available to treat him after the transplant in terms of deciding, you know, how long you treat this patient and when do you stop. Because what you do with these people is to accumulate AMR antimicrobial resistance very fast. So the same antifungal that was working prior to transplantation if you continue to transplant and you continue afterwards, may not be as effective as it was before. So be very careful at continuing long-term antibiotics going into transplantation and beyond.
And just the last question would be, since he has got ACLF, so when do you think in ACLF, when are you not transplanting? In other words, which organ failures or how many organ failures you are not considering the patient for a transplant in general in ACLF?
I think we are up for time, but I don't have a lot of time to talk about it. But as you might have seen, that, you know, based upon the data from the US, validated in a cohort of patients in Europe, we've developed a new score. It's called the SALT score. It's named after Vinay Sundaram, who led the whole of the program that you've read about, which is, so there is, again, as I said, hierarchy of organs. So multiple anatropes, respiratory failure is bad, old age is bad, MDR rose is bad. So it is combining 6 variables to define a risk score for mortality, which you can discuss with the patient as you move forward. So in our situation, we would not transplant a patient in whom the expected risk of death within 1 year was more than 60%.
Right. So thank you everybody for that wonderful discussion, and also thank Dr. Nipun for the slides.
That was a great start to the day and a very stimulating discussion. I thank all the honorable experts and the panelists for joining us. We'll now move to the first floor, which is Hall Konark, where the presidential oration is about to begin in a minute. Thank you everyone for your time. We'll be reconvening here at 11:30 a.m. for the next session of the day. Thank you everyone. Have a nice day. Right, good day everyone. Welcome to Hall Barabati. We are back after the orations and the plenary session to start the second session here at Hall-2. This is an exciting session on novel concepts in hepatology. So I request all of you to settle down as we have 3 excellent talks lined up for you. I would request honorable chairpersons for the session. Dr. A.V. Sivaprasad sir, Dr. Ramesh Kumar sir, Baldev Rana sir, P.K. Agarwal sir, and Dr. Setu Babu sir. I think we're still waiting on him. Please sir, grace the stage with your presence. The session on novel concepts in hepatology 1 is all yours, sir.
I think, we are refreshed after the tea coffee break and the orations, and it's time to start the session. And may just, call upon Professor Dhiman sir to give his talk, very importantly, whether it's infection or sepsis, which comes first or in hepatic encephalopathy. And let's hear from Sir's vast experience of decades.
Thank you, sir. That's the framework of my talk. You all know that the infections and the inflammation precipitates a patient with the decompensated liver disease with the hepatic encephalopathy. That is the first part that I am going to discuss. In the second part, the new hypothesis is that even infections are not there and the person has hepatic encephalopathy because of the certain pathogenetic mechanisms, they can also predispose the infections also. Let me see the first part. The first part, whatever our current understanding, the clinical manifestation of the hepatic encephalopathy is primarily a pathogenetic interplay between the osmotic stress, that is the swelling of the astrocyte, and the oxidative stress, nitrosative stress, that is the reactive oxygen species. And this can be initiated or triggered by the several mechanisms, including the inflammatory cytokines, hyponatremia, ammonia, or the benzodiazepines also. After these interactions, several changes occur, particularly the covalent modification of the protein RNA, that is the RNA oxidation, senescence, and the gene expression which is altered. And that leads to the astrocytic or the neuronal dysfunction, and the abnormal synaptic plasticity and disturbed oscillatory network, and ultimately resulting into the manifestations of the hepatic encephalopathy. And many other mechanisms which can precipitate, they have to go to the similar pathway of basically the osmotic and the nitrosative and the oxidative stress. They include infection, excessive protein intake, bleeding, and trauma. So that is the current understanding, that the infection or the systemic inflammation can lead to the hepatic encephalopathy. And you know, overt HE complicates the course of the cirrhosis in 1/3 of the patients at some point during their clinical course, and the high mortality observed. There is only 36% survival at 1 year and the 15% at the 5 year. And the community acquired or healthcare related infections occur more than 50% of the hospitalized patient with the cirrhosis. And the most common infections you all know, SBP, UTI, pneumonia, cellulitis, and so on. And they can all progress to the HE, other organ failures, mortality in patient with the cirrhosis. Infections are also associated with the longer hospital stay and the higher risk of the death also. And most of the infections in cirrhotic patients are caused by the enteric bacteria. You know, whenever there is a gut dysbiosis, there is a lots and lots of the pathogenic organism in the gut, and they translocate and ultimately can cause the infections also. And the sepsis favor acute decompensation of the cirrhosis and may lead to the HE, renal insufficiency, shock, and the acute on chronic liver failure. So this is the cartoon that I want to tell you. Basically, in patient with the cirrhosis liver, they have the gut dysbiosis, that is the CDR ratio, which is the ratio of the useful good bacteria and the pathogenic bacteria. It is about 2 in normal person, but in cirrhotic it is less than 1, and even more or less in patient with the decompensated cirrhosis. And this gut dysbiosis leads to the development of the or production of the ammonia and other mediators of the hepatic encephalopathy. And at the same time, you can see that in these patients, there is an intestinal barrier dysfunction, and there is small intestinal bacterial overgrowth also. And that leads to the translocation of the bacteria and their products. That is the bacterial endotoxins, what you call them pathogen-associated patterns also. That is the lipopolysaccharides or flagellants and so on and so forth. And once they interact with the TLRs, in the particularly the 4 and the 9, they ultimately initiate the immune response and the release or the formation of the pro-inflammatory cytokines leading to the systemic inflammation. And I like to tell you that the ammonia and the systemic inflammation causes, they are synergistic in causing the neuroinflammation and finally the HE. So once there is a systemic inflammation, that means there are pro-inflammatory cytokines in the blood. They are IL-1, IL-6 or the TNF-alpha. How they reach to the brain, that is more important. That is the brain signaling. One is that once these cytokines, they are in the blood, they goes to the brain parenchyma through the active transport. And otherwise, you can see that this is a blood-brain barrier, the endocytes or the endothelial cells, they are the important part and they are activated and they produce the mediators. Ultimately, they activate the astrocytes and the microglial cells. Once they are activated, they produce the full repertoire of IL-1, IL-6 and the TNF-alpha, that is the pro-inflammatory cytokines. And these cytokines, ultimately, they activate microglial cells, astroglia also, and production of the pro-inflammatory cell. They causes the altered neurotransmitter, ultimately the cognitive impairment or the symptoms of the hepatic encephalopathy. That is something that the inflammation and the infection causes. And there is a mounting evidence for the role of the infection or the SIRS in exacerbating the symptoms of the HE. There are the few studies, particularly from the Debbie Shawcross group also, what they have demonstrated that the presence and the severity of the minimal HE in cirrhosis are independent of the severity of the liver disease and the plasma ammonia concentration, but markers of the systemic inflammation are significantly higher in those with the minimal HE compared with those who did not have. And there are many other examples also. There is a significant deterioration of the neuropsychological test scores in patient following induced hyperammonia, that the ammonia after the feeding it is induced and during infection, but not after the resolution of the infection, suggested that the infection may be an important role in modulating the cerebral effect of the ammonia in the liver disease. And finally, even in the severe grades of the hepatic encephalopathy, that is the grade 3 or 4, a prospective study demonstrated 46% of the patients to have positive cultures and a further 20% have evidence of this trial SIRS. Increasing grades of the HE were associated with the SIRS and the neutrophilia, but not the ammonia. That signifies the importance of the inflammation or the infection. Now moving to my second part also, that if the ammonia is not associated with the infection, hepatic encephalopathy, if it is not associated with the infection itself, it can cause the infections also. So I would like to discuss one study that is recently published in 2021. And this is from the AIMS and the UCL London also. That is the combined study. 709 consecutive patients from the two institutes, AIMS and the UCL, they were incorporated and prospectively maintained clinical database in these cirrhotic patients admitted with the acute decompensation. Infection and the HE data collected on admissions and the occurrence of the de novo infection assessed for 28 days after the admission. EASL cliff organ failure criteria were used to determine the presence of the organ failure, and multivariable analysis using the logistic regression model was used to assess the predictors of 28-day mortality and de novo infection. Before I come to the results, I'll just want to tell you the differences between these two cohorts from the AIMS as well as from the UCL. Here you can see the males and the younger patients who were predominantly present in the AIMS cohort, and the MELD was significantly higher. And you can see the ITU admissions, only 15% in the AIMS cohort versus 100% in the UCL, and although the de novo infections were observed in 16% in the AIMS and the 30% almost double the infection. And what they have done, that they divided these patients, 709, into the 4 groups. First group, no baseline OHE or no infection. OHE with no baseline infection, no OHE but baseline infection, and lastly when both are present. Here what they have demonstrated after multivariable analysis, that it is the presence of the overt hepatic encephalopathy and the admission to the ITU is basically independently associated with development of the infections also. And if you look at this curve also, that is the survival probability, you would observe these two lower curves, they are basically having the hepatic encephalopathy and they have the survival probability the least. On the other hand, without HE, but it cannot be explained by the underlying severity of the liver disease. What the author suggested, that the presence of the OHE and the de novo infection may be an operative mechanism for the higher 20-day mortality in patients who have the overt hepatic encephalopathy. That is not only the evidence, we have searched the evidence in other literatures also. At least 3 studies I would like to quote over here. There is an occurrence of the infection preceded the development of the HE in patients with paracetamol-induced ALF. However, the reverse was observed in patients with non-paracetamol-induced acute liver failure. The mechanism we don't know. In sub-analysis of the canonic study in patients with the acute decompensation of the cirrhosis, a similar association between HE and the occurrence of the de novo infection was observed also. And coming to the minimal hepatic encephalopathy, association is also observed in these patients. Compared to no or minimal HE, grade 1 HE has more marked evidence of the systemic inflammation, higher spontaneous neutrophil respiratory bursts, and the bacterial translocation and subsequent infection, with infection being most common complication necessitating the hospital admission. That is the 3 evidences beside that paper that I could find. What are the mechanisms actually? If it is only the brain or it is the CNS which is causing the infection, there are the other situations also. For example, and what they have demonstrated, that CNS injury induced immunodepression. Immunodepression can happen after the cerebral injury in the form of the traumatic brain, the spinal cord, as well as the and it has been demonstrated that there is an increased risk of the infection. And this CIDS predisposes infection through mechanism including impaired natural killer cells as well as the T cell activity, reduced peripheral blood lymphocyte with reduced proliferation and the cytokine production. That is the one mechanism. Sympathetic nervous system, hypothalamic pituitary adrenal axis and the parasympathetic nervous system, they have been shown to regulate the immune mechanism. Any alteration in this system can also lead to the immunosuppression, immunodepression, and ultimately the infection also. And in one animal study in the rat model, what they have demonstrated, if you do the splanchnic sympathectomy, it prevents the spontaneous bacterial translocation from the gut to the mesenteric lymph node and ultimately decreasing the incidence, the severity of the systemic spread of the E. coli. How much minutes? 2 minutes? Yes, it's okay. How there is another possibility that the ammonia can also causes the infection by altering or affecting the neutrophils. What have been demonstrated that the ammonia impairs neutrophil function, which is mediated by the activation of the P38 MAP kinase pathway that leads to the excessive reactive oxygen species release and the systemic inflammation, oxidative state, high spontaneous oxidative burst, and the decreased phagocytosis. Means ammonia basically affecting the neutrophils, therefore the clearance of the bacteria is lower down as is causing the increasing incidence of susceptibility for the infection. Ladies and gentlemen, that I would like to conclude. You know all these mechanisms I have just told you. The infection and the inflammation can lead to the altered neurotransmission and ultimately symptoms of the hepatic encephalopathy through one common mechanism, that is the osmotic stress and the oxidative and the nitrosative stress also, and through the same pathways other causes, precipitating causes, they can also cause the hepatic encephalopathy. Here That is the first time I have seen this, and I could find the three mechanisms. So one is the hyperammonemia, which is causing the activation of the P38 MAP kinase pathway, ultimately neutrophil dysfunction and decreased phagocytosis leading to the infection. CIDS, that is the immunodepression caused by any brain event that can also cause an alteration in the sympathetic nervous system, hypothalamic pituitary adrenal axis, and the parasympathetic nervous system. Alterations here, they can also cause the immunosuppression, immunodepression, because these immune pathway is regularized by these excesses also, ultimately leading to the infection. And with these words, I would stop over here. Thank you so much.
Thank you, sir. I just thought I'll initiate the discussion. But all the topics are not the same. Okay, the seat is yours. They don't like me, so they don't want me to.
Want me to? I can reply now.
It is all a common discussion at the end, so let's follow this.
The next speaker will the optimal use of blood products in acute variceal bleeding, and will be taken up by Arpan Mohanty.
Good morning, everyone. The topic of my presentation is optimal use of blood products in acute variceal hemorrhage. My name is Arpan Mohanty, and I'm an assistant professor of medicine at Boston University and Boston Medical Center. I would like to thank Dr. S.P. Singh and Dr. Deseja for inviting me to INASL. This is my first presentation in India, and it is particularly special as it is in Bhubaneswar, because I may be a novo Bostonian, but I'm a true Oriya. The purpose and scope of this presentation, we will discuss key concepts that guide the use of blood products in acute variceal hemorrhage. To do so, we will understand the pathogenesis of variceal rupture. We will discuss the effect of volume expansion and blood product transfusion in cirrhosis. We will review the current guidance statements and consider challenges in their implementation. The goal for this is to develop an in-depth understanding of the pathophysiologic principles with relation to acute variceal hemorrhage, so as to guide subsequent management, specifically with relation to a restrictive transfusion strategy. So I know that this session is called Novel Concepts in Hepatology. However, I would be completely amiss if I don't show you years of data that have led to our understanding of blood transfusions in acute variceal hemorrhage. So the first concept I would like to introduce is that variceal hemorrhage is a portal hypertensive event, and it is unrelated to hemostatic failure. Okay. There are several animal as well as human data to support this, but I will show you some human data that show us that the severity of variceal bleeding is directly linked to portal pressure. Firstly, we have this study in which there were 65 patients who presented with acute variceal hemorrhage, of which 23 had a poor outcome, which is early rebleeding and failure to control bleeding, and 42 had an uneventful outcome. You can see that on the x-axis. They underwent a portal pressure measurement, and you can see the hepatic venous pressure gradient on the y-axis. So patients with a poor outcome had a higher HVPG, and 83% of these patients had a HVPG with greater than 20 in the poor outcome group, as compared to 28% in the uneventful outcome. So in acute variceal hemorrhage, HVPG of 20 millimeter of mercury and above predicts a poor outcome. Then I will show you this classic meta-analysis from D'Amico et al., where they studied these studies which studied decrease in portal pressure with medications. And HVPG reduction was defined as a portal pressure less than 12 or a 20% decline from baseline. And they showed that people who achieve, in patients that achieve portal pressure reduction, they have less bleeding. They excluded this McCormick study for heterogeneity, and even then the odds ratio were pretty significant for reduction of portal pressure and its positive effects on subsequent bleeding. This indirectly again shows that the severity of variceal bleeding is directly linked to portal pressure. And this portal pressure is the major determinant of variceal wall tension. So we'll call that T variceal wall tension, and it is directly proportional to this transmural pressure, or PTM. It's also proportional to the radius of the varix, and it's inversely proportional to the width of the varix, okay? So this transmural pressure is the difference between the pressure in the esophagus and in the varix, okay? Now the variceal pressure is directly proportional to the pressure inside, to the portal pressure. So as the portal pressure increases, your transmural pressure increases, your varix stretches, the radius of the varix increases, and the width of the wall decreases. And that when tension becomes critical, we get variceal rupture. The next concept is that blood volume re-expansion in setting of active bleeding leads to an increase in portal venous pressure. So patients without decompensated cirrhosis have an impaired capacity to accommodate fluid. And this supports the statement that I previously made, and I'll show you some studies that showed that. Now, this is a study from 1966, which was done by Jim Boyer, who's one of my teachers, and he did this when he used to live in Calcutta. So what he did is that he studied pressure volume response curves to expansion of plasma volume with a liter of 6% dextran. So he measured splenic pressure, which is a surrogate of portal pressure, and IVC pressure. Now, if you look at the x-axis in both the panels, it is the time. And the y-axis is the change in pressure, okay? Now, the top panel is a patient without ascites. So after you give this liter of dextran, the splenic pressure rises, the IVC pressure rises, but around 1.52 hours, it comes down, okay? But the second panel is a patient with ascites. Here, the pressure goes up, okay? And it stays up even after 24 hours. So patients with decompensated cirrhosis, they are unable to accommodate fluid. And this similar concept is from this paper by Zimin and Kessler. They took 3 measurements of portal pressure in 7 patients, and they gave them increments of 500 ml of either dextran or blood, right? And there was almost a linear relationship between the blood volume and the portal pressure, okay? So as we give more blood products, the portal pressure rises. Now, mortality increases with the quantity of blood product transfused. In acute upper GI hemorrhage, a restrictive transfusion strategy is better than a liberal strategy. And I would be amiss if I don't show you this Villanueva paper that showed that the probability of survival is higher in a restrictive strategy group than in a liberal group. A restrictive strategy being keeping the hemoglobin around 7. It is important to note that none of these patients in this study, they were I think 951 patients, none of them were hypotensive. They did not have cardiocerebrovascular comorbidities. And they looked at death at 6 weeks by subgroup. And it's in the subgroup of patients with cirrhosis and Child-Pugh A, the risk of death was lower in the restrictive group than in the liberal group, but not in the Child-Pugh C group. And they had similar MELD, about 10, in this Child-Pugh A and B group. Now, we did a study a couple of years back in which we looked at fresh frozen plasma. And this transfusion, we showed that it has no benefits and it's potentially harmful. This was a retrospective study across 5 centers, and we looked at patients who received FFP. There were 100 patients, and 144 did not receive FFP. We looked at mortality at 42 days and failure to control bleeding, adjusting it for age, MELD, and HCC. And this adjusted OR was pretty high. As it was retrospective, I cannot say that this is true for sure, but it had no benefits and it's potentially harmful. Now, the last concept is that correcting INR is not beneficial in acute variceal hemorrhage. You would think that recombinant factor 7 would help the INR, but in this randomized controlled trial, it did not help the composite endpoint of failure to control bleeding at 24 hours, failure to prevent rebleeding, or death in 5 days. So the odds ratio here was 0.8, and it was not significant. Now, also, FFP transfusions in clinical practice are rarely useful, right? Now, typically we would give 4 to 6 units of FFP to correct coagulopathy, but in only 10 to 12% of patients, the PT will go up by 3 seconds, okay? Now, there's a Hallbrook formula, right? It calculates the amount of FFP needed to correct INR in patients who receive warfarin. And if we extrapolate it to patients with cirrhosis, one would need like a lot of FFP to fix the INR, right? And the expected pressure with that amount of FFP, you can see in the third row, is pretty high, okay? So FFP transfusions in clinical practice are rarely useful. Now I go on to the guidance statements. The first is that the packed red blood cell transfusions should be performed conservatively with a target hemoglobin between 7 to 8. The transfusion policy in individual patients should consider other factors. And I highlight this because these other factors remain ill-defined: cardiovascular disorders, age, hemodynamic status, and ongoing bleeding. You know, we cannot often set a target for hemoglobin in variceal bleeds. Sometimes rapid transfusion protocols are initiated, and the results of the restrictive transfusion study that I showed you are not generalizable to patients with concomitant cardiovascular or cerebrovascular disease. The next statement is that variceal bleeding due to portal hypertension and variceal bleeding is due to portal hypertension, and the aim of treatment should be focused on lowering portal hypertension rather than coagulation abnormalities. I hope I showed you enough data for that. Conventional coagulation tests, namely prothrombin time and INR, and activated partial thromboplastin time, do not accurately reflect the hemostatic status of patients with variceal bleeding. Now, I'll show you some challenges to it. You know, the clinical perception for FFP in variceal bleeding lacks current evidence, and it varies across clinical specialties. Now, in the US, a lot of people take care of patients with a variceal bleed. So first, you know, the patient comes to the ER and then gets admitted to the ICU, where we have our emergency medicine colleagues and our critical care colleagues. You know, hepatologists don't run the liver ICU, okay? So I did this study in which, you know, I provided a survey to across 11 centers to gastroenterologists and emergency medicine providers and critical care medicine providers. You know, 40% of the gastroenterologists replied, but only about 20% of the emergency medicine and critical care physicians, so I clubbed them together. And I asked them if FFP transfusion is an important tool in management of variceal bleeding. And you know, this is like apparently a very polarizing question. So while this blue line, right, the gastroenterologists strongly disagree, the rest of them think that, yes, it is an important tool, okay? Then when I asked them, in patients with cirrhosis and variceal bleeding, FFP is effective in correcting INR? Like, nobody really believes that, okay? But they're all gonna give it, okay? So then I asked them, correcting INR due to cirrhosis improves outcomes like rebleeding and mortality? Most of them disagree, okay? Gastroenterologists, emergency medicine physicians, critical care, everybody disagrees, okay? But they will give FFP when hemodynamic instability influences the decision to transfuse FFP or platelets. So you can see that about 40% of gastroenterologists, as well as, you know, emergency medicine or critical care physicians think that. So, you know, when there's a lot of blood, there is a lot of transfusion. And, you know, we'll talk about how we can fix that. So the next guidance statement is that there is no evidence that platelet count and fibrinogen levels are correlated with the risk of failure to control bleeding or rebleeding. However, in the case of failure to control bleeding, the decision to correct hemostatic abnormalities should be considered on a case-by-case basis. And I highlight that again because that is a challenge and it remains ill-defined. Next, in acute variceal hemorrhage episode, transfusion of FFP is not recommended as it will not correct coagulopathy and may lead to volume overload and worsening of portal hypertension. Recombinant factor 7A is not recommended in acute variceal hemorrhage. So it's not all doom and gloom, okay? Blood products transfusions have declined over time, and this is the data from a US database called the National Inpatient Sample, which has about 97% of the hospitalizations in the US. And you can see that blood transfusion, that's packed red bloods, is around 35% of patients with varicose bleed get it, and about 12% of all patients with varicose bleed get FFP transfusions. And with multidisciplinary consensus and institutional transfusion guidelines, we can further probably encourage appropriate blood transfusions in varicose bleeding. Now, who is getting all the blood products? So, that data that I showed you before, I split it by ACLF and no ACLF, where ACLF is the solid line, and the dotted line is no ACLF. And most transfusions are in people with ACLF. Okay, PRBCs, they're declining, but still they're more in people with ACLF. So that is a challenge because ACLF is an independent predictor of rebleeding, and the effect of blood product transfusions on hemodynamics in the setting of ACLF is really not known. And with that thought, or rather that pot boiler, I'll take your leave. Thank you.
Thank you, Dr. Arpan. Will you please take the chair? Now I'll call upon Dr. Meena Bansal. She's going to talk on antifibrotics in liver disease. Are we there yet? Dr. Meena.
It's there? Okay. Great. Thanks so much to the organizers for inviting me to give this exciting talk. These are my disclosures. So I'm going to briefly talk about fibrosis and determinants of progression, lessons learned from clinical trials, and really talk about whether cirrhosis reversal is a little bit different. So irrespective of the etiology of liver disease, whether it be viral hepatitis, alcohol, or MASH, it's important to recognize that fibrosis is really just the normal, natural wound healing response in the liver. The cell central to this process is the hepatic stellate cell, which normally resides in the space of Disse between the differentiated hepatocyte and the fenestrated endothelial cell. In the quiescent state, it is a vitamin A-rich cell that produces predominantly type 4 collagen. With any injury, it undergoes classic phenotypic changes, which include contractility, proliferation, and now the production of predominantly types 1 and 3 collagen. Now, this is data from hepatitis C, but the concept holds true irrespective of the etiology of liver disease. Most patients develop cirrhosis over about 30 years. However, there are patients who are rapid progressors, and there are people who will never develop cirrhosis. I think we've all had patients 70 years old, have had hepatitis C since teenage, and they don't have cirrhosis. And there are a number of genetic risk factors. This is such a cirrhosis risk score for hepatitis C. And for NASH, we hear a lot about PNP-LA3 and HSD17B13. We know that the PNP-LA3 CG polymorphism is associated with fibrosis progression and HCC risk in NAFLD and alcohol-related liver disease, and it increases the risk of cirrhosis in hepatitis C patients. It's also associated with increased liver stiffness across a range, even 12 to 40 kilopascals, indicating it affects fibrogenesis and progression to cirrhosis. On the other hand, HSD7B13 is a loss of function variant that is protective and decreases transaminases, decreases the risk of alcohol and non-alcoholic related cirrhosis, and protects patients with NASH. Now, we're all born with that initial genetic predisposition. Some of us are slow fibrosers, some of us are rapid fibrosers. But then superimposed on that, there's a complex interplay between concomitant liver diseases, the impact of social determinants of health, environmental factors, coffee drinking, alcohol, smoking, etc., such that our actual disease course, someone can be born a rapid fibroser and now becomes a slow fibroser. And when we talk about design of clinical trials, you have a heterogeneous population. When a patient comes in to enroll, you have no idea what their genetic predisposition is and some of the environmental factors. And so if by chance you had rapid fibrosers randomized to the placebo group compared to the treatment group, you would wrongfully think that your drug was actually antifibrotic and effective. On the other hand, it would be great if we knew that up front and we had better stratification into the two groups. While this would be ideal, it's not really practical in clinical trials because, one, you don't know people's genetic predisposition up front. Two, if you enroll just that small group, when you look to get approval for that drug, they're going to say, well, you only tested in this group. Certainly, it would shorten trial duration, but it's certainly not practical, and ad hoc analyses are really what's being used to try to determine this now. There is clear evidence in virtually every liver disease as well as animal models that both fibrosis and cirrhosis are reversible. However, not in everyone, and there may be a point of no return, and I'm going to spend some time on that for cirrhosis. So what are determinants of fibrosis reversibility? First, the more rapid the onset, the light, fluffy collagen is much easier to regress. What is the extent and type of cellularity of the scar? The more cells you have within the scar, the macrophages that give rise to the proteases to actually degrade the collagen, the more cross-linking you have, how long that collagen has been sitting there, the more insoluble it becomes. Elastin in mature cirrhosis is more resistant to degradation. How thick are the fibrotic bands? Because that, again, determines inaccessibility to proteases and greater architectural disarray. The balance of those matrix metalloproteinases and their inhibitors, and then other factors. We talked about genetic determinants of fibrosis progression. Are there different determinants of fibrosis regression? So there's a number of therapeutic approaches for antifibrotic therapies. Obviously, removing the injurious stimuli is probably the best antifibrotic, but decreasing stellate cell activation, one approach. Second, once the stellate cell is activated, can you inhibit some of the phenotypic changes like fibrogenesis? And then once the stellate cell is activated, can you promote its apoptosis, senescence, or transdifferentiation back to the quiescent phenotype? So what lessons have we learned? I use NASH because there's more data on that in terms of reversibility of fibrosis, since one of the primary endpoints for most studies right now is a greater than 1-stage improvement in fibrosis. Now, Sanigraviroc was actually, in my mind, an ideal antifibrotic. It's known to, it's a CCR2, CCR5 antagonist, which will inhibit Kupffer cell activation, decrease the migration of monocytes into the liver, and has direct antifibrotic effects on stellate cells. And after 1 year, in this phase 2b study, they did indeed see fibrosis improvement by 1 stage. However, after 2 years, that effect was lost. And the lesson learned from this really is that everything really needs to be moving in the right direction for you to really believe the results. In this case, there was no reduction in ALT, there was no reduction in other fibrosis biomarkers like ELF or PRO-C3. There was a reduction in some of the inflammatory markers. So the kind of lesson learned here was that if everything has to be going in the same direction, it has to make sense. When you start to have these disconnects, the likelihood that it's going to be an antifibrotic becomes lower. Now, obeticholic acid is antifibrotic. They demonstrated fibrosis improvement in greater than 1 stage with no worsening of NASH. You can see a dose-dependent effect of 10 milligrams and 25 milligrams of OCA. Unfortunately, the FDA did not approve this because of safety concerns, including pruritus, gallstones, DILI. People talked a lot about this minor increase in LDL of about 11 milligrams per liter early on, but that normalizes actually after 1 year independent of statin status. Now, resmetirom is probably most likely to be FDA approved. This is the thyroid hormone beta agonist. Arun mentioned it as well yesterday. Has a very favorable cardiometabolic profile. And in their top-line data, they demonstrated that the 80 milligram and 100 milligram dose resulted in a 1-stage improvement in fibrosis. Now, this is an ongoing study, and we'll follow for clinical outcomes, but clearly we saw fibrosis reversibility. Now, FGF21 is a very interesting molecule with pleiotropic effects, And this is the phase 2b Harmony data, which also showed improvement in at least one stage of fibrosis without worsening NASH. Again, a dose-dependent effect of 39% and 41%. And what's interesting about this drug is they had a very high proportion of patients who had both NASH resolution and fibrosis improvement. And I think that's really important, and only a 5% in the placebo arm. Lanifibranor is the pan-PPAR agonist that has balanced activity across the alpha, delta, and gamma. And here again in their phase 2b 24-week study, you see that there is an improvement in both the 800 and 1200, but the effect is better in the 1200. And things are moving in the right direction. We saw a reduction ALT, AST, GGT, improvement in glycemic indices, good cardiometabolic profile, decrease in other markers of fibrogenesis. There is a weight gain, like with the other PPAR gamma effects, of about 2.5 kilograms, really just a shift in the visceral to subcutaneous fat. So an ideal candidate for this might be a diabetic non-obese with no history of CHF. Now I want to spend a minute on cirrhosis because I think that this is a really important concept. Cirrhosis is not a single stage. When we say F1, F2, F3, F4, it is the longest stage of fibrosis. Patients can be in the cirrhotic phase for 10 years, maybe more. But a lot of things are happening during that time. Someone who just transitioned to cirrhosis is very different than somebody who's been sitting there for 10 years. There is extensive cross-linking happening. There is the fibrotic bundles are getting thicker. They're getting more acellular. And therefore, the ability to remove that scar gets progressively harder and harder to the point where you might ultimately hit a point of no return and will not see reversibility. And I think this picture kind of captures it all. Both are cirrhosis. By definition, both are cirrhosis. But I think we can all agree, if you look at the panel on the right, that scar is very thick. It's going to be very hard to reverse. And so when we have clinical trials in cirrhosis where we're asking the patients to decrease by one stage, and we don't know where they have been, unless you've been following a patient, they just transitioned to cirrhosis, you don't know how long they've been cirrhotic. And so expecting in a heterogeneous group of cirrhotics to see a one-stage improvement in fibrosis is a very tough bar in my mind. And this also demonstrates it quantitatively that the liver collagen bundle is not linear across fibrosis stages, and as you get further along, that increase in collagen content increases at higher stages. So it's no surprise that we have a number of failed studies in cirrhosis. I won't go through them all, but they're listed here. And so we really need to think differently about how we enroll cirrhotic patients and how we assess an antifibrotic effect. So do we really need to think about substratification of cirrhosis for inclusion, and can AI help us? Can some of the newer technologies that augment our pathologists' assessments? So this is just one example of second harmonic generation, 2-photon excitation fluorescence to quantitate fibrosis. So this actually now gives you a more quantitative assessment of fibrosis. You can calculate mean septal width, the cellular to acellular ratio, which will impact reversibility. They've also now added Q-septa and Q-nodule to address some of these challenges in cirrhosis and developed a SNOF score. And so this is by histoindex, but there are other AI-based technologies that allow us to get more granular and look at improvement in fibrosis, antifibrotic effects, without this hanging on to this one-stage decrease. So what have we learned to date? Reversal of cirrhosis will require long intervals and better substratification. It will be reversible in some, depending on the time in the cirrhotic phase. Collagen content continues to increase rapidly, even in cirrhosis. 1 year is not enough time to see downstaging by traditional biopsy methods. Use of AI technologies to better substratify on biopsy for enrollment or assess treatment effect if we repeat a biopsy. Hopefully we can convince people that we don't need to biopsy, but if we do, let's make better use of it. The point of no return will vary from patient to patient. We still don't understand genetic determinants of reversibility, and ultimately only outcomes matter, so we should try to eliminate biopsy. And we may require a facilitator for reversal. HSP 47, Arun just mentioned yesterday that they closed the program, but that siRNA is targeted against activated stellate cells, and at least in hepatitis C. So even when you cure hepatitis C, some cirrhotics do not improve. And so they were testing this siRNA to promote reversal. But unfortunately, I heard yesterday that their program closed. Now, earlier stages of fibrosis are much more reversible. We do need earlier biomarkers, though, to assess responder status, because not every drug will work for every person. We really have to have those biomarkers look at the mechanism of action. Everything needs to be moving in the same direction to increase confidence in the effect. Again, trying to get away from liver biopsy as an endpoint. We have high placebo rates because of the heterogeneous population that I mentioned, natural history of the disease, and of course sampling variability and inter-observer lack of concordance. We may need combination therapies and cell-specific targeting to really maximize antifibrotic effects. And so I think we've learned a lot over the years about antifibrotic therapies, and I do think that they are on the horizon, and we look forward to a great discussion. Thank you.
Three wonderful talks. Thought I'll start with the last topic. You would agree with the statement that fibrosis is reasonably reversible?
Yes.
You need to attend to the etiological cause, let's say Hep B, or autoimmune, or Hep C, or even the fat, whichever it is. So if that can be attended, it can be reversible. Fibrosis is a precursor for malignancy, right or wrong?
Correct.
But only one small thing is in hepatitis B, you may not get fibrosis, but you can still lead to HCC. That's only one small area where even NASH, even without fibrosis, it can develop malignancy is one of the things. I think the genetics plays a major role in that.
Yeah, I mean, I think for
No, that's not for me actually.
No, I think that was my end.
Yeah. The only problem is you also have to look at the possibility of statins. That will be very interesting. Or we are looking at anti-diabetic control like semaglutide.
Yep.
Maybe that could make a lot of difference in reversing the fibrosis.
So, do you want me to respond
Yeah, one more
to that?
last comment. You were showing two beautiful slides which are very educative. Are you serious about me? No. Okay. The question is the two slides which you have shown, that the histological activity index which we used to talk and the liver frailty index which we are now talking as a non-invasive marker for measuring the fibrosis. I think they have a lot of impact in real-time practice.
Yeah. So I'll address this. So one, in terms of statin use, absolutely. And in fact, in Bovino, they recommend statins should be started in all patients with Child's A and B cirrhosis. There, it's more of a portal pressure effect. Statins don't have a strong antifibrotic effect, so it's more in sinusoidal endothelial cells, the effect. So, and you can comment on that as well, but certainly statins, I think, are going to be backbone therapy for all cirrhotics, so I agree with that. The other question about
doing the liver frailty index or non-invasive markers is as good as doing a histology.
Yes, I think that it depends on what you're trying to achieve, but I do think that we're good enough with non-invasives. The key is which biomarker, because they're not all the same in all the different etiologies, and that's where I was saying your mechanism of action. If you have a biomarker that demonstrates engagement of your target, so for example, resmetirom is a thyroid hormone beta agonist. It's one of its downstream molecules is sex hormone binding globulin. And those that had an increase in SHBG were the ones who had an antifibrotic effect. So there are different biomarkers that will indicate whether or not you can anticipate an antifibrotic effect. And even in the different ELF may work in some, but not the other. So if you're affecting fibrinolysis, fibrogenesis, there's a lot of different factors, but absolutely. And in terms of the hepatitis B, that's a different issue because of cccDNA integrating into the hepatocyte. So that's a different beast. And even in NASH, it's rare, they have F3 or F4. I mean, it's really rare to see somebody with NASH have HCC in the absence of at least F3, so yeah.
I was actually surprised with one paper where they showed HCC without much fibrosis. Okay, coming to the second.
Sir, can I ask something, to Dr. Meena?
Yeah.
In extension to your questions. What drug are you using as of now for the reversal of fibrosis in the US? As till date, all the drugs have almost phased out. And there is nothing, in India we have got seroglitazar which has been approved.
Yeah, there's no antifibrotic except for...
So what exactly do you do? Once you do so much of testings, you do a lot of investigations, we try to find out even with biopsy or with AI whatsoever.
Yeah.
What exactly do we do next to the patients in that case?
I mean, there's nothing except for trying to treat their upstream drivers of fibrosis at this point in time. So semaglutide, the GLP-1, you mentioned that for diabetes. So at 72 weeks, they didn't see an antifibrotic effect. We'll have to see, we're doing the Essence trial now, which is longer, and we'll see if there's an antifibrotic effect. They had a very high placebo rate, which I think is what...
Do you use OCA there now?
Do we use OCA? Only for PBC.
That's
and the
true.
dose is 5 milligrams, very different. No, we do not use OCA, no.
Yeah, excellent talk, all three speakers. My question is to Dr. Arpan. So what is your comment on using ROTEM or TEG for guiding FFP transfusion in these patients?
Well, I think there is data from India that shows that, the number of FFP transfusions can decrease if you use ROTEM, right? But you need a good fellow who can run for you with that sample, okay, and then run the test and, bring it back. It is not very practical without that fellow. I used to be that fellow, so that's why I remember how it was done. But it has only shown that it decreases the number of FFPs given. They never studied the outcomes. So I don't think it affects outcome, but FFP in general wouldn't. But there is no prospective study to that.
So in US you are not using?
Well, I showed you that a whole bunch of people get FFP. In the study that I did, 40% of people got FFP. And it is not just the hepatologist who control this transfusion, right? There are so many physicians the patient comes in touch with. So, yeah, there remains to be seen.
My question, I'm so sorry. My question to you is, tell me what decides I give FFP or not. Let me give you a scenario where a patient comes with liver disease and his INR is 6 and he just had blood and stopped. You mean to say we won't correct it, wait till something happens or he not normally recompensates or something? Where is the guideline?
So if your hemoglobin is stable, I will not give it. And even if your hemoglobin is not stable and the bleeding has stopped, you're able, and this is variceal bleeding that we're talking about, and we are able to get to endoscopy, I don't think that, you need to correct, we do not correct INR to put bands.
Is it the Hall's opinion that somebody comes with an INR of 3, 4, 5? We don't give FFP? Is it acceptable to everyone, or we are restless to give FFP? No. That's right. No bleeding? No. Yeah. I think you got your point well driven.
Good, thank you.
That's very nice.
But
Sir, yours.
Yeah, my question is for Professor Meena Bansal. Ma'am, what is your thought on metformin as an antifibrotic drug and its combination with a statin, because it's a cheap drug and there is some data which suggests that it works on hepatic stellate cells?
Yeah, metformin's a great drug and pretty much first line for anybody who has insulin resistance even prior to diabetes, pre-diabetes. Meta-analysis do not show any antifibrotic effect. So it unfortunately has not shown an antifibrotic effect, but is generally good for the liver. There's some weight loss with it. So it is first line, but it doesn't have an antifibrotic effect.
Dr. Bansal, please. Is fibrosis of liver
specific to etiology. If we look at the children, galactosemia, biliary atresia, tyrosinemia fast go into cirrhosis. Within months, they go into cirrhosis. Whereas if you find in adults a long duration of various stages going into fibrosis and consequently cirrhosis of liver. So is there any difference in the pathways of development of fibrosis depending upon the etiology of the liver diseases?
Biliary cirrhosis can be very quick. If you ligate the bile duct, you will get, so secondary biliary cirrhosis happens very quickly. And I don't know if in the cases that you're talking about, it's kind of a bile duct issue, but certainly that cirrhosis goes very quickly. I'm not a pediatric hepatologist, but certainly there are times when you can develop very quickly.
Dr. Dhiman, just wanted to know from you, is it only that the inflammation cascade is required for encephalopathy? Is there any other mechanism whereby we can have the precipitation of encephalopathy other than the risk factors which you already know, based on the mechanisms?
The mechanism I have just told you about, the one is the osmotic stress, and another is the oxidative and the nitrosative stress. And in that, it is the astrocyte swelling also, and that subsequent, you have seen all the cascade of the events leading to that. And that is the basic actually. So this is the final pathway kind of a thing. And before that, all kinds of precipitating event, be it a infection causing the inflammation or the ammonia or the benzodiazepine also, through different mechanisms, they also call the same thing also, and ultimately leading to the clinical manifestation of the HE. Even if you say that there is no precipitating factor is there, and there is a deterioration in the progressive deterioration in the liver function also, they also basically go through the same mechanisms also, and systemic inflammations play a very, very important role in those subgroup of the patients. SIBO is small intestinal bacterial overgrowth. In cirrhotic patient, I have told you the CDR ratios goes down below 1, and in decompensated cirrhosis maybe 0.5, 0.6 also. So in the CDR, there is a overgrowth of the pathogenic bacteria in comparison to those who are the useful bacteria. And there is a leaky gut also. So once there is a leaky gut, then there is a translocation of the bacteria and their products also. And what you call the pathogen associated. And when they interact with the TLRs, actually, particularly 4 or 9 also, then there is a systemic inflammatory response. Systemic inflammation. So SIBO, that is we have already shown in the patient with the cirrhosis also, there is a presence of the SIBO in quite a sizable number, even at the low-grade encephalopathy, MHE also. So the SIBO infections, altered CDR ratio, and the gut dispasses, they all play a very, very important role in the pathogenesis of the HE.
So that's why you can say that it's the other things first or the infection first.
No, it is difficult to say. I think it is a different scenarios also. You all understand there is a wide literature as far as the infection or the inflammation causing the HE. But the other way around, there is the observation in the clinical that there is no infection, only hepatic encephalopathy, but causing the infection also. And it has been demonstrated and proven in at least one study that I have discussed now here only, that in only multiple analysis they have demonstrated that it could be because of the de novo infection. rather. But it is only the one study, it has not been substantiated, so we cannot say further that this is the only mechanism. There could be the multiple also, which I have discussed with you.
Hey. My question is to Dr. Bansal. Excellent talk. We've been using SGLT2 inhibitors in diabetic fatty liver. We don't have, our patient don't accept biopsy, but what we have seen is that the FibroScan score, higher, pre-treatment higher score, came down to lower score. So what is your take on?
So this is, did you say SGL2?
SGLT2 inhibitors, glyphosins.
Yeah, SGL2, yeah. I think that tracking the stiffness on FibroScan makes perfect sense. It hasn't been, I mean, they're being studied. You know, they're being studied now in patients with NASH. So we don't have the data yet, but certainly if you're treating their diabetes, like you have an indication to treat them, it has good cardiovascular protection as well and kidney protection. So certainly it makes sense to treat them. The effect on the liver remains to be seen if it actually has an anti-fibrotic effect, but nice to know that the FibroScan liver stiffness is going down.
Thanks.
But I guess his CAP score is also coming down. Are you sure? His CAP score is also coming down. That's how inflammation comes down, fibrosis comes down.
I think we have to close here. We've already crossed the time. We had a good discussion. And, okay, last question.
My question is to Dr. Arpan. Ma'am, what is the role of cryoprecipitate in the variceal bleed? Is there any role? Because it might not increase the portal pressure as compared to the FFP, number one. And number two, in a patient of cirrhosis with varices who is not bleeding at present, but who has coagulopathy, INR of 4 to 5, and if any procedure is planned in that patient, like suppose we have to do sclerotherapy for hemorrhoids or any other procedure, so do we need to give FFP prior to that? Because it might increase the risk of portal pressure and increase the risk of bleeding. But if we don't give, then there is the risk of procedural bleeding. So prior to the procedure, do we need to give FFP or not? So what is the rationale behind this? Can you please tell that?
Okay, so the second question is that, you know, just like last week, I think, we published in Gastro that that FFP, INR is not predictive of procedural bleeding, especially if you want to do routine procedures like paracentesis. I think you can band without giving FFP. I would not give, the risk of bleeding is overstated. Now, your first question was related to cryoprecipitate. You know, there is this group of patients who do this hyperfibrinolysis, right? You know, they make these hematomas, they bleed, they have menstrual cycles from hell. You know, then in those patients, I sometimes think of giving, but there is no data to support that.
Thank you all. I think we'll have to close the session at this stage. I thank all the speakers for excellent presentations and a very fruitful discussion.